I mean, from spinal drainage, I mean, our indication for spinal, if we are going to cover the thoracic and abdominal aorta, usually we'd like to use the spinal. If we're just covering up to the celiac, most of the time we don't do that. We look at the subclavian, if it's open or not, this is also, and the internal iliac arteries, you know. If they are both open, they'll be less, you know, favorable for drainage. But if the subclavian, we're going to cover subclavian. If the internal iliac is compromised, we're going to cover even down below to the abdominal aorta, we prefer to put a spinal drain, yeah.
For the non-ruptured aneurysms stage, no spinal drain. I mean, spinal drains have a 3 to 5% risk of complications. For ruptures, the patient has, true ruptures, the patient will have a coagulopathy, even if you can't measure it. So to persuade your anaesthetist to put a spinal drain in somebody who has a coagulopathy is quite risky. I personally believe that good blood pressure control contributes far more to spinal perfusion and preservation of collaterals does than the marginal benefit of draining 10 millimeters of mercury or 50 millimeters of mercury of CSF. So I think it's blood pressure control for ruptures and stage for elective.
Thank you.
If you don't drain and patient develop a paraplegia right after surgery, you can put a drain after that, but the sooner you do it is be better. So just be sure if you don't put a drain, patient wake up with paraplegia, be sure you put a drain right away. Thanks.
Go to the floor, please. Yes.
Thank you all for the excellent presentations. I had a question regarding the staged procedures. Now, did you notice any increased rate of endoleak? That's number one. And when you do the second procedure, do you use the same axis, or did you have any problems with the axis?
Obviously, the endoleak issue, you've created or left an endoleak at the first procedure, and that allows the aneurysm and the intercostals and lumbars to be perfused. And what happens over the week interval is related to the principles of Virchow's triad, in that you have partial thrombosis from the most proximal aspect of the aneurysm, taking the intercostals out stage-wise. The second stage, for example, if we do the thoracoabdominal endograft and it's a branch graft, then we only need access through one groin. So we have a percutaneous approach to the other groin, and we then have a clean incision a week later to deploy the limb extension. Similarly, I put the branches in from an incision under the clavicle on either side. A week's delay between the two doesn't make reoperation or re-exposure of the axillary artery difficult at all. It's not a hostile reoperation if it's a week apart.
I mean, I appreciate what Donald is saying, but probably we have a slightly different practice. We don't do staging, and I'll tell you why in a second. We almost always revascularize the left subclavian if we're stenting a long segment, and try to keep it in circuit. For the spinal drain, we're so keen to put it almost all the time except emergencies. The reason we shy away from staging for two cases: one, we had significant embolization to the SMA from the branch. We did it a week later. And the second one, we had a rupture while we were waiting to stent. So I think we're still, the jury's still out, and there are different practices.
Any question? I have one question regarding the dissecting thoracic aorta, traumatic. What has been clear from Dr. Ayman, that there is change, it just will be late interfere. So the question, of course, there is sometimes whereby the CT showing that you have to interfere immediately on the spot. But is there, I'm talking about the gray area, which is telling you that, shall I do it or shall I wait? So do you have the gray area, it is clear for you just to interfere or not?
Delayed only in stable patient. If patient is unstable, you have to take him and treat him.
No, I'm talking about the stable one. I'm talking about the stable one.
Delayed, so you delay him and stabilize do the other procedure.
No, the condition, I'm talking about the stable, the condition. This is stable one. Shall you wait if you want to wait? how long you will wait. I know that sometimes you can wait for even sometimes 5 days, 1 week, it's nothing. But you don't predict the issues that prediction of this dissection will be ruptured. So you can't predict it.
So when we say stable, it means you give the chance for other surgeries to be done. Like if the patient comes with a splenic fracture, you take him and stabilize him with the splenic fracture, giving time for other procedure. But if and there will be no patient with isolated aortic trauma. This patient has not been discovered. It will be the first one. So that means if the patient is stable, take him to the other surgeries, stabilize, be sure that he's in a stable position so he will benefit from the procedure, what you're doing, from the aortic.
Again, it's the same thing. We take them to the angio suite, we embolize, and then we stent. But the bottom line, they need to be stented as soon as possible.